welcome. So today we're going to talk about atrial fibrillation and the management, focus on rhythm control strategy based on medicine-based evidence. So the first thing we have to go to the guidelines, and the guidelines specifically divide atrial fibrillation with four stages. The stage that we are interested in is the stage 3 and stage 4. Stage 3 divided A, B, C, and D. A is paroxysmal, less than 7 days. B is persistent, more than 7 days, but less than 12 months. C is long-standing persistent atrial fibrillation, more than 12 months. And D is when the patient is free of atrial fibrillation after having a successful atrial fibrillation ablation. And then stage 4 is permanent atrial fibrillation, which is the patient, the physician mutually agree to not pursue anymore rhythm control strategy. So they abandon that strategy and they focus on rate control strategy through different methods. So this is the also like a picture showing the guidelines. This is the stage 1 through 4. And they specifically the treatment of atrial fibrillation, they base on three pillars. The stroke risk, which is the anticoagulation, optimizing the risk factors, which will be like exercise, diabetes, sleep, and symptom management, which is based on two things, either rhythm control or rate control strategy. Rhythm control being so put it the heart in normal rhythm, so make the heart to listen the sinus node, versus rate control strategy, just controlling the heart rate without caring about if the patient is in atrial fibrillation. So they also discourage the terms such as chronic AFib. Before, if you have a long atrial fibrillation, you used to classify as chronic AFib. No longer anymore. Valvular or non-valvular atrial fibrillation. That is surprising. Why? Because in the guidelines says like they class if you basically had like valvular AFib, you should anticoagulate the patients with a warfarin, but they don't like to use this valvular AFib anymore. Valvular AFib also is patients who have like mechanical mitral valve and moderate to severe rheumatic mitral stenosis. And the first thing that they focus is class 1 in the recommendation. Always talk with your patient to either which one is the best suited for your patient, either rate control, rhythm control strategy. Also, they emphasize that if the patient doesn't have like a heart failure, if you choose rate control, choose the rate less than 100 up to like 110 beats per minute. So what is all this debate comes about? Because you have like a stroke risk, this is another topic, risk factors, okay, but this rate and rhythm control, this is the debate that was since early 2000. So that's why like they came with like two trials, race one and a firm trial. Race one was done in Europe, was a smaller trial, just like around like 500 patients, and a first trial was a bigger trial that was done in the States. What they found is they found like that rhythm control strategy, rate control strategy was kind of similar. Rate control strategy was not inferior to a rhythm control strategy in prevention of death and mortality, but they only included patients with persistent atrial fibrillation. And what they found is like just 40% of the patients, 39% of the patients in the rhythm control group were in sinus rhythm. So there was a lot of things that could skew the finding of these trials. But it's surprisingly because the first trial also found the same thing, and they found like there is no advantage, and they even like say that in order for you to achieve the rhythm control strategy, sometimes we choose like a lot of drugs, and those drugs have like a lot of side effects. That's why like look, first of all, in a first trial is 23% of the patient had like a congestive heart failure, and they use almost 60% on the patients imiodaron, and only ticosin was used in 0.6% of the patients. So obviously, imiodaron had like a more side effects. That's why like probably that was one of the reasons why they didn't find any evidence. any like evidence that rhythm control strategy was superior to the rate control strategy. What is all that mean is if a patient went to a doctor in the early 2000 and he would ask like, oh, I don't want to take that medication with a lot of side effects, the doctor probably will say, based on the evidence, it's okay because the evidence show that rate control strategies have like similar outcomes that rhythm control strategy. And this is another like graphic that shows the same thing. In 2008, also remember that just was 23% of the patients were included in the first trial. So they were wondering, what about with the patients who had like heart failure? What will be the outcomes? And they included patients with like a ejection fraction less than 35%. They followed the patient for 37 months. Surprisingly, for the primary outcomes, which is diet from cardiovascular causes, 27%, 27% in the rhythm control versus 25% in the rate control. Not even in heart failure patients, they found like evidence that putting a rate in rhythm control strategy was beneficial. That was surprising. Look, patients with atrial fibrillation congestive heart failure, a routine strategy of rhythm control doesn't reduce the death from cardiovascular causes. So up to 2008. So what they focus instead, they focus on like 2010. We're gonna find if rate is similar outcomes to rhythm control strategy. We better know like which is the target rate. So they came out with like a race 2 trial, and they want to see the strict rate control, which is less than 80 beats per minute, or like the lenient rate control, which is like less than 110. Which one is better? And they found in patients with permanent atrial fibrillation, lenient rate control is as effective as a strict rate control and easier to achieve. So up to like 2010, a doctor was, okay, this is easy. Patient with atrial fibrillation, rate, rhythm control doesn't matter. I'm gonna put it in rate control, and even in rate control, I don't have to achieve like a, a string, like a strict like a rate control. Just achieve like less than 110. Easy medicine, right? But no, medicine is not like that. You have to look for what is the truth. So that's why I came. The first trial into 2020 was ISAFNET 4 trial, and they compare early rhythm control therapy in patients with atrial fibrillation. Early rhythm control meaning less than 12 months diagnosis. What they found in the patients who had like early rhythm control therapy was associated with lower risk of adverse cardiovascular outcomes than usual care. So that was shocking. I don't think so because like there was like a lot of retrospective studies showing that there is benefit of rhythm control, but we have to find a better rhythm control strategy for a lot of patients, especially in young patients, 50 years old. They don't have like a heart failure. I'm not gonna uh, I'm not gonna place the patient a lot of medications to achieve like a rhythm control, or I don't gonna have like the patients using rate control when we know like the atrial fibrillation characteristics for developing heart failure. So in those patients, that was like the first one of the first trials that showed evidence, randomized trials, so evidence that early rhythm control therapy in patients with atrial fibrillation is beneficial. They enrolled patients who were more than 18 years old, and they defined like a early atrial fibrillation less than 12 months. Early rhythm control requiring antiarrhythmic drugs or atrial fibrillation with ablation. Now we are gonna talk about like a new thing. That was not only the drugs, was like ablation. That's why like ablation is the new kid in the block. We're gonna see what is the benefit from now. And look here, they use at 2 years, almost 20% of the patient ablation. Remember that imiodarone in the first trial with the first trial was like 60% of the time. Here, amiodarone is just 10% of the time. The Fetalite 5%, remember, increase, and then flecainide and also propafenone is more. So that is why like they found evidence that rhythm control strategy in early atrial fibrillation was beneficial because we are using other tools, not the same thing as we use in the prior trials. That's why we found benefit there. Look here, paroxysmal was a 30%, almost a 36%. So that means like if you have those patients to achieve normal sinus rhythm, especially those patients with paroxysmal atrial fibrillation, early atrial fibrillation, less than 12 months, those patients do better. That's why like when you go to a doctor, to an electrophysiologist, if you have like the atrial fibrillation early, it's better because they can do more things. They can ablate easily in those patients. So the primary outcomes, as you can see, reach statistical significance. Early rhythm control was better than rate control. This is the graphic as well. That's why like there is 2A recommendations in patients who have like a recent diagnosis of atrial fibrillation less than 1 year. Rhythm control can be useful to reduce hospitalization, stroke, and even mortality. This trial changed guidelines. We can see here. And now we're going to continue with the other guidelines. What they say in patients with reduced LV function, like meaning heart failure and persistent atrial fibrillation, high burden, a trial rhythm control should be considered, should be recommended. So this is class 1 indication, and they recommended that to evaluate whether atrial fibrillation is contributed to reduce heart failure function. It is also 2A recommendation in patients with symptomatic atrial fibrillation. Rhythm control can be useful to improve symptoms. And 2A indications in patients with a recent diagnosis with atrial fibrillation, rhythm control can be useful to reduce hospitalization, stroke, or mortality. You see how the guidelines switch. In the early 2000s, we had like rate and rhythm control is similar, basically. But now with the new evidence, they focus more on rhythm control. And they say like, okay, most of the patients try rhythm control first. Don't leave it in rate control anymore. And rhythm control should be a standard. So then in 2004, 2010, we had like a new system and they come out with like, okay, we have been approaching wrongly this how to achieve rhythm control. What about if we just apply this? And they come with the thermal-cooled atrial fibrillation trial. That was the first trial to evaluate a catheter ablation. A catheter ablation at that time, they used radiofrequency. We're gonna see what is radiofrequency, what is cryoablation, and what is the new pulse field ablation. And what they like compare to determine the efficacy of catheter ablation compared with antiarrhythmic drug therapy in treating symptomatic paroxysmal atrial fibrillation. Because we know paroxysmal atrial fibrillation is easy to treat. So they want to see which one is better, catheter ablation versus the antiarrhythmic. And they included like 106 patients in the catheter ablation group, and the antiarrhythmic 61 patients. What they found is 66% of patients in the catheter ablation group remain free from a treatment failure versus 60% treated with the antiarrhythmic. Remember, prior trials show like just like 39% of the patients were in normal sinus rhythm. In this 66, and which 16% patients with antiarrhythmic drugs. So it was a huge difference, 66 patients. And major 30 days treatment related adverse events was 8.8 patients treating with antiarrhythmics, 4.9 patients treated with catheter ablation. Still, 5% of the patients have like a major 30 days treatment adverse events. What we are more concerned about it is like events related to the peri-procedure outcomes of that. Also, like for example, a stroke in 30 days and all of that. So at this point, we have like a new tool to treat atrial fibrillation, which is radiofrequency for treating a catheter ablation for treating paroxysmal atrial fibrillation, and they're trying to confirm it is a safer and is effective. 66% of the patients. This was the characteristic of the patient. Atrial fibrillation duration, as I told you, like less duration is better. And they included even like up to 5 years, and the ejection fraction was a 60%. They included like relatively healthy people, the and you can see there like the antiarrhythmics that they use. Immunoglobulin they use like just 10% of the patient in the antiarrhythmic groups. So they compared with the Dofetilide was used Soralol 37%, propafenone and flecainide. They were more used on those trials. But what they concluded as well, this is the design. Sorry, they went through the pulmonary veins isolation, and this is the design how they designed it. They allow up to like 2 repeat ablation procedure within 80 days. And now there was another trial in 2012. They compared still the radiofrequency ablation as initial therapy in paroxysmal atrial fibrillation. Now, it's an initial therapy, so meaning like those patients didn't receive any antiarrhythmics before. Because the first trial, Thermocool, they included patients who received antiarrhythmics, but they wanted to see like, okay, what about if we treat these patients who didn't receive antiarrhythmics and we're going to see the outcome. So they randomized 294 patients with paroxysmal atrial fibrillation and no history of antiarrhythmic drugs. Um, there was no significant difference between ablation and drug therapy groups in the cumulative burden of atrial fibrillation. So 24 months, the burden of atrial fibrillation was significant. The burden of atrial fibrillation was significantly lower in the ablation group than in the drug therapy group, and that was statistically significant. One death in the ablation group was due to procedure-related stroke. So what they concluded in comparing radiofrequency ablation with antiarrhythmic drug therapy as a first-line treatment in patients with paroxysmal atrial fibrillation, they didn't find significant difference between the treatment groups in the cumulative burden of atrial fibrillation over a period of 2 years. So this trial said like, oh, hold on, if you have paroxysmal atrial fibrillation and you choose a catheter ablation, unfortunately, there is no significant difference. But if you try first an antiarrhythmic, there is a huge difference, 66 versus like a 13%. So that's what like the guidelines in the latest guidelines said like first try drugs and then like ablation, because this radiofrequency mantra trials show this. And there was the characteristics of the patients were like a little bit younger, 56, 54 patients, ejection fraction more than 60%, just like a few patients with an ejection fraction of 40 to 60%. Look, there was like another thing, interesting thing in this trial is there was a tamponade 3 patients and death 3 patients as well. That probably was during tamponade, and pulmonary vein stenosis 1 patient. Total of patients who were like adverse events was 25. So that was another problem. It's like although you have like this new tool that has shown to be effective, has a lot of peri-procedure risk, and you want to avoid that basically. Then it came like the RAF2 trial, still radiofrequency that was published in 2014, ablation versus antiarrhythmic drugs as a first-line treatment for paroxysmal atrial fibrillation. That was kind of a similar trial, and what they found like a 72.1% in the antiarrhythmic group and 54.5% in the ablation group experienced the primary efficacy endpoint, and this was statistically significant. So this trial showed like, okay, we show that radiofrequency is better in the primary outcome compared to antiarrhythmic. And there was 4 cases of cardiac tamponade in the ablation group. There's still 4 cases of tamponade that they found in this trial. So what they concluded is among patients with paroxysmal atrial fibrillation without previous antiarrhythmic drug therapy, radiofrequency ablation compared with antiarrhythmic drugs resulted in lower rate of recurring atrial fibrillation at 2 years. So, however, recurrency was frequent in both groups. So, up to this point, radiofrequency based on the RAF2 trial showed like, okay, it could be effective. What they included only patients with ejection fraction of more than 60%, age were younger, 56 and 54%, and paroxysmal atrial fibrillation was also like 65%, 98.5%, and 96.7%. So this is just like the graphics that show you like what I told you is the radio frequency was better than antiarrhythmic drugs. And this is just the design. And now you have up to this point radio frequency ablation, which is like the bottom. Radio frequency ablation has like a lot of peri-procedural adverse events. It's not that effective. You have like one trial, RAF2 trial that show like it's more effective, but the other trial didn't show effectiveness. That's why like it was developed like another tool. This is cryoablation, which basically is the same concept. Go through the pulmonary veins and ablate there. Why is that? Because it has been shown that that is the anatomic site that most atrial fibrillation triggers comes from. The first trial was fire and ice trial. This was like, okay, we have like this new tool, is cryoablation. We want to compare with radiofrequency ablation. So they compare in non-inferiority trial. They compare they follow up for 1.58 years the patients, and what they found like was non-inferior. Cryoablation was non-inferior to radiofrequency with respect to efficacy for patients with paroxysmal atrial fibrillation, and there was no significant difference between the two methods regarding like the overall safety. And there was like also they already discovered that cryoablation is non-inferior to radiofrequency. They want to see like, okay, causal AF, catheter ablation for atrial fibrillation with heart failure. Remember that in 2008 there was a trial, AF-CHF trial, showing that rate versus rhythm control was similar. What about if we show like catheter ablation atrial fibrillation in causal AF? What they found is after a median follow-up of 37 months, the primary composite endpoint occurred significantly fewer in the ablation group than the medical therapy group, 28 versus 44.6%. Which was statistically significant. That's why catheter ablation for atrial fibrillation in patients with heart failure was associated with significant lower rate of composite endpoint of death from any cause or hospitalization for worsening heart failure than was medical therapy. So causal AF showed, okay, if you have heart failure, catheter ablation is the goal because it's going to reduce the hospitalization, it's going to reduce the mortality. And the operator has to perform like 50 ablations, so meaning has to be experienced operators, and they included like ejection fraction of less than 35%. They included paroxysmal or persistent atrial fibrillation, and all the patients were required to have like a device, ICD or CRT-D. Those patients, the primary outcome was statistically significant, but everything changed. Why? Because came the Cabana trial. The Cabana trial was published in 2019 in JAMA, and they basically want to compare catheter ablation versus antiarrhythmic drug therapy on mortality, stroke, bleeding, cardiac arrest. Why? Because they already showed that catheter ablation in heart failure was beneficial. Now we're going to expand catheter ablation in all the patients. What they found, unfortunately, among patients with atrial fibrillation, the strategy of catheter ablation compared with medical therapy didn't significantly reduce the primary composite endpoint of death, disabling stroke, serious bleeding, or cardiac arrest. However, The estimated the treatment failure catheter ablation was affected by lower than expected event rate and treatment crossover. So we're gonna see if this trial actually showed like it was not beneficial. So there was randomized 2,000 patients, 1,000 patients each group. But the patient has to have like two or more episodes of paroxysmal atrial fibrillation or one episode of persistent atrial fibrillation in the prior 6 months. So we're like a new atrial fibrillation, early atrial fibrillation, less than 12 months. And look, there was 300 patients cross over to the catheter group, 300 patients from the antiarrhythmic group. Also, like we're gonna see like it was mostly severe and heart failure symptoms was like mostly like 30% in both groups 3 and 4, and the ejection fraction was low, only 5% of the patients. Persistent was like 40% of the patients and paroxysmal 40% of the patients, and rhythm control group, rhythm control strategy, one rhythm control drug, and least in both groups was 80% in both groups. So they didn't find like a statistically significance to a catheter has an advantage over rhythm control in those patients, and this is the graphic. However, when you go to analyze all-cause mortality, mortality or cardiovascular hospitalization by itself, all-cause mortality doesn't have like any difference. But mortality or cardiovascular hospitalization is statistically significant catheter ablation. It's better than drug therapy. And also like recurrent of atrial fibrillation, so meaning like being free for atrial fibrillation is better with a catheter ablation. So if you go to Cabana trial, you're gonna see, although there is no difference between groups, yeah, there is difference there. You are remaining free of atrial fibrillation symptoms. Also, like a pericardial effusion with tamponade was the most common adverse event in catheter ablation patients. Pulmonary vein stenosis was rare, and atrioesophageal fistula was not observed. So at this point in Cabana trial, they told you like, okay, if you are experienced in performing those studies, the adverse events that the operator has is pretty low as well. Then it came the first trial showing this new technology in 2021. By the way, in Cabana, there was in 2019. 2021, there was a STOP AF first trial of cryoablation. And they basically investigated patients with paroxysmal atrial fibrillation, not previously receiving any rhythm control strategy, and they like randomized in cryoablation or the drug. And what they found in the ablation group, initial success of the procedure was achieved on 97%, and at 12 months, 76% in the ablation group was successful versus 45%. Remember, this is a huge win. 66, now 74.6%. And even in the rhythm control strategy, it's also a huge win, up to like 45%. Why? Because we know how better to treat those patients. So what they concluded is that the cryoablation as initial therapy was superior to drug therapy in the recurrence of this atrial arrhythmia in patients with paroxysmal atrial fibrillation. So they included patients with a 60-year-old was the mean. Those patients also like a cardioversion in the prior 12 months. Electrical is just 18% of the patients, and pharmacological just like 8%, 14% of the patients. But the bottom line is there was like a low peri-procedural risk with the cryoablation, so meaning like cryoablation is better than radiofrequency. And now, early AF, cryoablation or drug therapy for initial treatment of atrial fibrillation. The previous one was for paroxysmal. Now they want to know, what about cryoablation as initial treatment? Patients who didn't take any antiarrhythmic medication before. What they found that among patients with receiving initial treatment for symptomatic paroxysmal atrial fibrillation, there was a significantly lower rate of atrial fibrillation recurrence with a catheter cryoablation than antiarrhythmic drug therapy. So up to this point, cryoablation is the way to go. And now that's why, like in many centers, they use cryoablation nowadays than a radiofrequency. So this is just the patient characteristics. The same thing they included like patients with paroxysmal because we already know that those patients are easy to treat. And if you want to show some benefit, you have to include those patients. And the endpoint was statistically significant. And though this was like the ablation anti-drug therapy percentage of time in atrial fibrillation, less with the ablation, as you can see here. And also like the side effects were less, just like a 0%, just one syncope or so forth and so on. So it was like this procedure was like so safe, just 1% of the all the time that you are going to have like any serious adverse effect. So what the guideline says nowadays is class 1 indications in patients with symptomatic atrial fibrillation in whom antiarrhythmic drugs have been ineffective or contraindicated or not tolerated or not preferred and continued rhythm control is desired. Catheter ablation is recommended. Class 1 indication is also class 1 indication in patients who have like a symptomatic paroxysmal atrial fibrillation in which rhythm control is desired. Catheter ablation is useful as a first-line therapy. Up to this point, we have like two class 1 indications, but in patients who already tried medication or in patients who basically, I don't want to take antiarrhythmic, I want to go for ablation. So it's class 1 indication. And also it's class 1 indication in patients with symptomatic or clinical significant atrial flutter. Catheter ablation is useful for improving symptoms, but this is well known already. So you have like three class 1 indications. Patient doesn't want to take medications. Patient already take medication in atrial flutter. Two indications in patients who are undergoing ablation for atrial fibrillation. Ablation of additional clinical significant supraventricular arrhythmia can be useful to reduce the likelihood of future arrhythmia. And it's also two-way indication in patients with symptomatic paroxysmal or persistent atrial fibrillation who are being managed with a rhythm control strategy. Catheter ablation as a first-line therapy can be useful to improve symptoms. Now, they also recommend patients undergoing ablations for atrial fibrillation, pulmonary pain isolation is recommended class 1 indication, but it's class 2B, meaning like, there is no evidence, include other things. Also, is in patients with recurrent symptomatic atrial fibrillation after catheter ablation, repeat catheter ablation or anti-drug therapy is recommended. So, and this is the risk that we have with different with the catheter ablations is basically less than 1%, all of them, and those are LA esophageal fistula, and most of those risks as we're with like a cryoablation. That's what like are used nowadays. Currently, cryoablation over radiofrequency. But we have another therapy developed, advancement developed. This is pulse field ablation. The first paper 2023, the INSPIRE study, they investigated this is safe, and the INSPIRE trial confirmed that safety and effectiveness of this newer therapy that was a pulse field ablation. They included patients, the same thing, paroxysmal atrial fibrillation, young patients, 58, 59, 60% young for trials, meaning, and there was no adverse events even. That was surprising in the INSPIRE trial. That was like prone to do like a vanguard study that was published recently in the Heart Rhythm Society 2026 that was held in Chicago. Why? Because we have like the new therapy that is amazingly, surprisingly good. What they concluded is among patients with persistent atrial fibrillation, they went for persistent. Why? Because I know that this therapy is superior. The risk of recurring atrial arrhythmia was significantly lower among those who receive pulse field ablation as a first treatment than among those who receive antiarrhythmic drug therapy. But we are going to see what is the actual evidence of this. This is just the pulse field ablation. They use the penta-spline PFA catheter. What they included is was a multi-center prospective randomized control trial. They used like the FARAPulse system was an intention to treat, meaning they include all the patients in both groups for analyzing, and they also include like a safety analysis performing because they want to see like how safe is this. We're gonna see why was this safety analysis included there. Inclusion criteria more than 18 years old was symptomatic persisting atrial fibrillation. Persisting atrial fibrillation means more than 7 days. At least one electrocardiographic documented episode within 180 days before randomization. Exclusion criteria was patients who had like a class 1 or class 3 antiarrhythmic drugs for 7 consecutive days of more than 24 hours or amiodarone within like 6 months before. What was the design of these trials? Now they include like a pulmonary vein isolation and the posterior wall isolation as well. So the atrium, you have like 4 pulmonary veins, 2 in each side, 2 superiors, 2 inferiors, and then you have like the posterior wall. So what they include is the posterior wall ablation as well. So in the antiarrhythmic drug, it was decided by the physician, but the amiodarone needs to be excluded. Why? Because they carry like more side effects. So, and after the blanket period, the patients could cross over to pulse field ablation. They also inserted this loop recorder to see what's going on with the atrium. What is interesting about study, by the way, like was followed by for 12 months, is that in the middle of the study, in October 2024, was stopped. Why was it stopped? Because 6 patients developed a neurologic events. So this was like resumed in November of the same year, but they resumed with like a different criteria. They excluded the patients who had like a CHA2DS2-VASc score more than 4, and they also required to the patients to undergo a screening for left atrial thrombus through like by like a transesophageal echocardiogram or a CT, and they also require the patients to be anticoagulated for at least 4 weeks before the procedure. So that was a significant blow to this study. So we will see like if affects or not. What was the endpoint of this? So this endpoint combine short-term success and long-term success. What is short-term success? It's electrical isolation of all the target pulmonary veins and pulmonary wall, or freedom from ablation during the blanking period. So meaning like the patient didn't have an ablation in the antiarrhythmic drugs. In the catheter group, they had like a isolation for all the target pulmonary veins and pulmonary posterior wall. Long-term success was a freedom from the use of immudarone through 12 months. And freedom from the following after the blanket period as well, of at least 30 seconds of symptomatic atrial fibrillation, flutter or tachyarrhythmia, at least 1 hour of symptomatic, 30 seconds for symptomatic, 1 hour for asymptomatic, or electrical cardioablation, cardioversion or ablation for atrial fibrillation, atrial flutter, or use of class 1 or class 3 antiarrhythmic drugs in the catheter group. There was also like a primary safety endpoint. What was the primary safety endpoint? Because we have this event, they included device or procedure related serious adverse events among patients in the combined pulmonary field ablation group. Why is that? Because remember, at the beginning there was like 2 groups, and then for included for the primary safety group, they added like another group to find like the primary safety group. How they analyze the data. So based on the 86 power for primary safety endpoint, They included like 247 patients, and they also like if they want like a 90% power for superiority, they should include like 285 patients. And this is the patient characteristics from December 2023 to February 2025. Just recently, they analyzed 484 patients, which 440 were enrolled, and then like 300 patients underwent randomization, and 100 patients underwent for primary safety, like they were included after randomization was done for primary safety event evaluation for those patients. And look at that, 200 patients were assigned to receive pulse field ablation, 28 withdrew from that, and out of like the 100 patients, 103 patients who went to like the drug group, 8% withdraw. So most of the patients completing the trial, 78 versus 169 patients. There was, this is the basic characteristics as well. There was 60 years old patients, ejection fraction is 56%. Those patients are with a persistent atrial fibrillation, don't forget about it. CHA2DS2-VASc score, they excluded already like CHA2DS2-VASc score more than 4. And atrial flutter as well, they included like a few patients there. And this is something interesting as well. The mean procedure time was 85 minutes. It's well known that if you undergo a cryoablation procedure, you're gonna spend like at least like 3-4 hours, and this was like just 80 minutes. So this procedure is quick. And this is the outcomes that they found. Treatment success is 56% in the pulse ablation group versus 30% in the antiarrhythmic groups. The hazard ratio is 4.46, which was statistically significant. So the treatment success, as we can see, was the short and the long-term event. A rate of freedom for atrial fibrillation was there. So that is what like they concluded that this trial was actually a positive trial for this. The event it was just 5% before the stopping of the trial, before the pause, and 6% after the pause. As you can see there, a stroke is kind of like 2 and 3%, 6 patients, and no stroke after the pause, which is huge as well, comparing to what you would expect, like 0. Remember, the Inspire says so is a 0. Now, online you're gonna find like a lot of critics about pulse field ablation. I think like this trial needs to be done again, although like show like superiority and keep like patients free of atrial fibrillation recurrence. We need more evidence. Thank you so much. Bye.